and welcome everybody. I'm Karen Siegel. I'm serving as the co-chair of the International Affairs Forum at the current time with my husband Jack. The International Affairs Forum, for those of you who are not familiar with our programs, we are here to advance understanding of the world and its critical issues through education and public dialogue. We are affiliated with Northwestern Michigan College and the World Affairs Councils of America. We just celebrated our 20th anniversary. We are nonpartisan and we are very much volunteer-based. On the back of tonight's handout that you should have, there is a list of our upcoming programs. I think it starts on the front and goes to the back. And I hope you'll agree that we bring an impressive array of talent and expertise to connect with the Traverse City area. We welcome you at future events, and if you'd like to get involved in supporting these and other programs, please contact us. We have some of the volunteers that we depend on helping us here tonight, and I'd like to personally thank them. They're running around with their little volunteer tags on, so thank you for helping out tonight. One of our goals is to partner with local organizations to be able to present special programming like our Ebola presentation tonight. We are particularly grateful to Indigo Health Partners, to Munson Healthcare, and to Northwestern Michigan College for their financial support for tonight's exceptional program. We'd also like to recognize our media partners, Up North TV, which is filming tonight's event and offering it as a live broadcast. And it's important to note that this is the first time that they're ever doing such a program here from Hagerty. And so they are also using this event to build a capacity that they will be able to offer for future events, because we have many great opportunities in this area. I'd also like to recognize IPR, which does so much to bring informed discussion to our community. Finally, I'd like to thank our esteemed panelists who have so generously given of their time in preparing for this event and who all have deep ties to this region. I think we're all very fortunate to live in a community that both produces Anders, who was born here, Terrie, who lives here, Ben Levy, who's coming on and whose mother is here tonight. We live in such a nurturing community that we produce people who go out and do great things in the world, and then they come back and help us all understand things. And then, of course, to our area attracts terrific professionals. So besides Wendy, Trute, Dr. Speirs, and Dr. Martin. So we really live in a wonderful community, and I'm sure I don't have to tell you that. Outside, before you leave, the Munson Healthcare has brought a number of very, very good documents that you can pick up, a number of brochures, and so that's just on the way out, and that is through their community health library. So that's a terrific resource for tonight. And now I'd like to turn it over to tonight's moderator, Dr. David Martin. Since 1978, he has been our community's resident expert on infectious diseases. Among many other positions, he is a former president of the Michigan Infectious Disease Society, and we are very fortunate to have him moderate this panel. Thank you all for coming.
Thank you. Well, thank you all for coming tonight, and obviously you know what the topic is. And I think as we think about epidemics in general, I think we have to keep several things in mind. Epidemics have been going on since the beginning of time, and all life forms on the planet suffer from epidemics of one type or another. And when we think about the various epidemics in history, like the Black Death, the influenza pandemic of 1918, the polio epidemics, and one of the biggest we've seen, the AIDS epidemic, what do we learn from those? And the answer is, well, we learn lots of things. But one of the things we have to learn is that each epidemic is unique. As my grandmother used to say, you know, son, if you've seen one epidemic, you've seen one epidemic. And we'd say, yeah, Grandma, finish your Jamesons and go to bed now. But you know, she was right, because if you think about epidemics, They occur at different times to different peoples, different cultures, different religions, different diets, all kinds of differences all over the world. Different organisms, viruses, bacteria, fungi, parasites. So there can be all kinds of things that can cause epidemics, and each one is truly unique. And each one occurs in a specific setting or population of people where they have their own economic system and their own political system. And that has to impact how we deal with those things. Now, technology has come along and changed how we view epidemics quite a bit. And technology is extremely helpful. And with the use of technology, we're hoping that we will have much more rapid diagnostics, which we certainly do, and much more rapid development of treatments and preventions for these diseases. So technology's been extremely helpful. But there's another part of technology that is kind of worrisome. And when you listen to some of the commercial news networks, not all, but many of them, you all realize there's a fair amount of hysteria out there. And as National Public Radio reported recently, if you look at all the news media attention to the Ebola outbreak, only 22% of it has been dedicated to what's going on in Africa. The rest of it's all what's going on in the United States. So with that, I think we need to get started and see what we can learn tonight. I want to first off thank the International Affairs Forum, and especially Karen Puchel, as you've just, I don't know where, there she is down there again. You met her already, and she's been a great help here. And Jack Siegel is down there. Where'd Jack go? There he was right in the front row. So thank you, Jack and Karen. I also like to thank Peg and John Zachman, who were very instrumental in helping getting this organized as well. So I'm going to go ahead and we're going to begin with our first speaker, who is Dr. Terrie Taylor, who's with Michigan State University. And Terrie has dedicated her life to studying tropical diseases, especially malaria. She is considered one of the world's experts in malaria. She has spent, for the past 28 years, she spent 6 months in Africa and 6 months back here doing research and treating patients. So she's been a huge benefit to our community. She is married to her husband, John Robert Williams, who's in the back, and I think many of you know John as well. So we're going to turn this over to Terrie, who's going to give us a summary of the epidemic to this time. Terrie?
Thank you. Thank you, everybody, for coming. It is my pleasure to lay the groundwork for the epidemic in Africa. So this is a very short introduction just to set the stage for the discussions that will follow. This is the Ebola River, and the virus was named for this river. This picture was taken by Peter Piot, who was part of the original investigation of the first outbreak, which was in 1976. And it started in a small hospital, and the experts were called in when 13 of the 18 members of the hospital team came down with this mysterious disease. And you can see from this epidemic curve, the top curve shows people who were infected from working in the hospital, and they were infected by direct inoculations with blood. There were inadequate supplies of syringes and needles. Those supplies were being reused. People were being continuously exposed. And then it spread to the community, which was down below. And overall, there were 425 patients that were part of that epidemic, and 308 died. Since then, there have been another 24 outbreaks of Ebola. The current epidemic is the 25th. And they've all occurred in Africa. I just would like to point out that our country could fit into this continent twice. This is a huge continent. And the current epidemic is focused in West Africa with the countries of Sierra Leone, Guinea, and Liberia, just on the westernmost corner. This is the epidemic curve of the current epidemic through the middle of September. The first infection probably occurred in Guinea, but someone who was exposed to a fruit bat, probably in December. And that person surfaced in Guinea in January, but it wasn't until March 23rd that the WHO was notified of this disease that had reared up again in Guinea. And the cases burbled along in Guinea. On June 5th was the first time that there was a case in Sierra Leone. That occurred because a herbalist in Guinea was Sierra Leonean. She was taking care of patients in Guinea. She got sick and died and went home, and her funeral was held in Sierra Leone, and 12 people were exposed during the course of her funeral. The Liberian epidemic also started. I should have mentioned that in early April. On July 20th, a healthcare worker from Liberia went to Nigeria and died. And that's ignited the outbreak that spread to Nigeria, which is near, but not adjoining, the three central countries. And then on August 27th, an overland traveler went to Senegal and introduced the disease to that country. Again, near and adjoining Guinea. Back to Guinea, Liberia, and Sierra Leone, the disease, the epidemic was taking shape. People were beginning to keep track of cases. This is the definition of a suspected case. A person with sudden onset of fever and contact with someone who may have had Ebola with 3 or more of the following symptoms: headache, vomiting, diarrhea, etc. Unexplained bleeding or sudden death of any unexplained cause. A person moves into the category of being a probable case if they were evaluated by a clinician, if they were directly in contact with an individual with Ebola, and probable and suspected become a definite case only when there's been laboratory testing. The initial studies were carried out in such a way that the basic reproductive rate of the epidemic could be described, and that is a number that's determined by how many people are infected by exposure to a case. And the original observations were carried out in a way that allowed the intervals to be detected between exposure and manifestations of the disease. So the rate of the epidemic could be calculated and predicted. After an epidemic matures, individuals can come up with a net reproduction number, which happens after an epidemic has plateaued. And that, again, allows for predictions of the future shape of the epidemic. This paper was published in the middle of October in the New England Journal of Medicine based on the observations up to the end of September, where the initial reproductive rates in Guinea, Liberia, and Sierra Leone were all well over 1. And an R of over 1 means that the epidemic can continue to propagate. Things settled down a little bit for the RT, but the doubling time was worked out to be 16 days in Guinea, 24 days in Liberia, and 30 days in Sierra Leone. And on the basis of those original observations came the prediction that many of us heard in late September, early October, that there would be 20,000 cases of Ebola by November 2nd. And the numbers have continued to accumulate in these countries. And we've seen this map before. These are the hotspot countries. So as of today, how do the actual numbers work out in terms of the predicted numbers? It's better. So Guinea has only 1,760 cases instead of 5,740. Liberia has less than predicted. Sierra Leone, almost up there. But instead of 20,000 cases, we have 13,241. And as of Friday, the total deaths on the African continent are 4,950. What happened to the outbreaks in Nigeria and Senegal? They were declared officially over in the middle of October. Once we've gone 2 times past the incubation period of the disease, which is 21 days for Ebola. So once we've gone 42 days with no new cases, it's closed. So it's over in Senegal and Nigeria. So what's the picture of Ebola in Africa today? It's there in a tiny corner of a very large continent. Thank you.
Thanks, Terrie. So next we're going to bring up Anders Kelto, and Anders is a correspondent for National Public Radio's Global Health and Development team. He was previously the African correspondent for public radio's The World, which I'm sure many of you have listened to many times. He has recently traveled to Sierra Leone, and he was reporting on the Ebola outbreak for NPR while there. Just got back on September 26th, and I think I heard him mention that he's on his way back over there fairly soon. So, Anders, we're anxious to hear from you. Thanks.
Thanks, Dr. Martin. And I want to just say a special thank you to Jack and Karen for organizing this event. I have to confess, I was not actually born in Traverse City, as I was introduced. I was born in Ohio, but my family moved here when I was 2, so this has always been my home. I live in Washington, D.C. now, but I tell people that when they ask where's home, I say, well, home is Traverse City, but I live in D.C. So. And I think this forum is just a wonderful event, and it's one of the many great changes that have been happening in Traverse City in recent years. And I think it's just making this whole community more vibrant. So thank you so much for organizing this. So I wanted to just start with a quick recap of the timeline of the response to Ebola. Terrie just did a wonderful job of laying out what was happening with the disease itself. So what has the response been like? Back in April 1st of this year, Doctors Without Borders, international relief group that many of you are familiar with, declared that this was an epidemic of a magnitude never before seen. There had been 24 outbreaks previously. This, they were saying, is serious, and we need to do something. Months went by. In April, nothing happened. May, nothing happened. June, nothing happened. At the end of July, they came out and made another public statement. They said Ebola is out of control in these countries. And they asked for more aid from the World Health Organization, who continued to basically poo-poo all of these cries for help. At the end of July, the president of Sierra Leone declared a national emergency. He was criticized because everyone said, we know this has been going on for a long time. What's taking so long? Then finally on August 8th, the World Health Organization, which is a division of the United Nations, finally declared that this was an international emergency, which started to create some response. And of course, this whole time, the disease wasn't waiting. It was continuing to grow. On September 16th, President Obama pledged $500 million, 3,000 troops, and said that they would build 17 Ebola treatment units, mostly in Liberia, to help aid with the response. And around that time, the international response from other communities also started to ramp up. So this was the time at which I went to Sierra Leone in the middle of September. The country was about to undergo a 3-day national lockdown. And I'm going to just try and sort of walk you through the experiences that I had when I was there. So first, this is a picture of the capital, Freetown. It's beautiful. It has these rolling, lush green hills. It's right on the edge of the ocean. It has really beautiful beaches. It's really a fabulous city. This is a shot of an average street, very crowded, looks like your sort of typical busy downtown African city. But life has changed ever since Ebola arrived and was declared a national emergency. The way people live there has changed. This is a hand-washing station outside of a supermarket in downtown Freetown. And pretty much any store, any supermarket, any restaurant that you walk into, you'll see one of these jugs outside, and there will be a sign like the one you see that says to wash your hands. You see signs everywhere. You see banners hanging on the sides of the road. You see posters in windows. All of them are about Ebola. They have information about Ebola. They tell you what to do if you have symptoms. They warn you not to have body contact with other people. It's inescapable. It has been integrated into their way of life now. And there's this whole culture that has evolved there of not touching. When I first arrived, I was introduced to someone, and I instinctively reached out my hand to shake hands, and the person just kind of looked at me and like took a step back and said, I'm sorry, but I can't shake your hand. And I was like, oh yeah, I'm sorry, and I felt stupid for having done that. But that's the new reality. People don't hug, people don't shake hands, and people are quite scared. The night before that 3-day lockdown that I mentioned, we went to a grocery store just to see what was happening. There was a lot of anxiety. People thought they might not have enough food to make it through these 3 days. They were going to have to stay at home for all 3 days. And there was a little bit of a rush on grocery stores at the end of the workday as people were sort of stockpiling, anticipating, being cooped up at home for 3 days. And this is the first day of the lockdown. So this is a street very close to the one that I showed you a picture of earlier. This is what it looked like when the lockdown was happening. What you see on the sides of the road is trash this is a market area. These are cardboard boxes and fruit and just trash that's accumulated on the side of the road. The only vehicle that you can see there is a military vehicle that's patrolling the city to make sure everyone is at home. And while everyone was at home, teams of health workers were going around to try and educate people about Ebola. Sierra Leone had gone through a sort of period of denialism early on in the epidemic where people didn't believe that Ebola was a real thing. And part of this lockdown was to convince people this is real and we are going to try and educate you on what you can do to prevent yourself. So this woman is a nurse who was going into this high-density part of Freetown where people are crammed into these tiny little shacks, open sewers, and she's telling them what are the symptoms of Ebola, what should you do if you get it, and they also were distributing bars of soap and showing people how to scrub their hands and telling them the most important thing is if someone is sick, try to avoid contact with them and if possible bring them to an Ebola treatment center. This is that same woman, and here you can see a little bit of the area where she was speaking. And part of the problem with this epidemic relative to others is that it got into urban areas, right? The previous outbreaks were in the jungle, they were in remote villages, and that's a big part of the reason that they didn't reach a huge number of people. But in this current outbreak, it made it to Monrovia, the capital of Liberia, where populations are extremely dense. It made it to Freetown, a city of 1 million people where lots of folks crowd into these, tiny little slum areas. The other way in which life has changed is you get your temperature taken everywhere. This is me at a police checkpoint along a main road between the capital, Freetown, and a city called Kenema, which was one of the early epicenters of the outbreak. We had to get out of our car and have our temperature taken about 10, maybe 15 times en route, and everyone was being subjected to the same thing. Additionally, travel is restricted. Public transportation is shut down in most parts of the country. It makes it very difficult to get food to market. It makes it very difficult for people to get to and from work. And this is all part of that change in lifestyle that has resulted from Ebola. As Terrie pointed out, there's only been a few thousand cases in each country. It isn't a huge epidemic compared to many others, but the fear of the epidemic has changed the country very dramatically in terms of all the ways that people live and also people's access to health care. So many health workers are scared of getting diseases that they've abandoned their positions. So if you get in a car accident and you're taken to the hospital, or if you get pneumonia and you go to the hospital, you may not be able to see a doctor, you may not be able to see a nurse. And it's those secondary effects of Ebola that have been far more of an impact than the disease itself. So this is at an Ebola treatment unit in Kenema. I don't know if you can see it, but I'm sort of on the left in a black t-shirt. I'm having my boots sprayed. They take fairly extreme measures to make sure that no one transmits germs in or out of these treatment units. So you have your boots sprayed, you have to have your hands washed, and if you are not a medical expert, then you are not allowed to go into the actual treatment units. This is my colleague, Peter Breslow. He was my producer on this trip. This is us speaking with a gentleman who has just recovered from Ebola. He's waiting to be discharged from the treatment unit. The two tarps that you see there are fences that make sure that anyone visiting people, and this is allowed, you're allowed to stand in this area and communicate with people, keeps a healthy distance, because the belief is that if you're that far away, you have 0% chance of actually getting the virus from someone. On the left is the head nurse at the treatment center. This particular hospital that we visited has seen 37 health workers die from Ebola. 37. over the course of a matter of months. And yet, despite that, despite the huge risks, a lot of people are there continuously risking their lives every time they go into this unit to care for people. Their staff was depleted, but they still had a core group of people who were there and working extremely hard. On the right is a doctor from the University of Maryland who was there with the World Health Organization, who did a 3-week rotation and was one of 2 operating doctors in the Ebola treatment unit. One of the stories that I did when I was there was about this young man. His name is Dauda Fulla. He's 23 years old, and he is an Ebola survivor. He came to the unit with his entire family, and he is the only surviving member of his family. His father died, his stepmother died, his sister died, his grandmother died. And when he recovered, he chose to take a job in the very unit where his whole family had passed away. He now is a phlebotomist. He draws blood from people who are receiving treatment. And because he has recovered from the disease, they believe, has immunity to it. So he is at much lower risk than the other health workers. But I was just very moved by his story and the question of why he would choose to work in this very place where he suffered and his whole family passed away. So I encourage you to listen to it, maybe when you go home later tonight. These are some other survivors at the hospital. It's very difficult for survivors to get home from the hospital. Another story that I did was about that very issue. So these children here and the woman on the left, and this family of 4 that you see here, these are all people who traveled great distances to get to this hospital to receive treatment for Ebola. Once they recovered, they didn't have a way to get home because there's no public transportation across the country. They don't own a vehicle. They are just waiting at the hospital trying to figure out how to get home. There's a dispute going on between their hospital and the hospital where they came from about who should transport them. This family had been living there for 2 months in an abandoned wing of the hospital and being fed by the nursing staff. And so for many people, the challenges of life after Ebola are pretty severe. They often return home and are sort of ostracized by their communities. You know, there's a lot of fear that they may still be contagious even though they're not. They're sometimes told, you know, we don't want you to sell your food at this market, or we don't want you using this tap to get water. Life can be very difficult, and often they've lost other family members as well. So the struggle doesn't always end with just getting well, and yeah. So I'll end for now on a little bit happier note. There aren't a lot of happy moments when you're covering Ebola, but this young man was at that same hospital in Kenema. He was also waiting to go home after having recovered from Ebola. And I did a story about him and a very interesting relationship that he had with one of the nurses at the facility. So he and his 2 brothers, he's 3 years old, his name is Ibrahim, and his brothers are 5 and 8 years old. And they, together with their mother, were brought to this treatment center because they all had Ebola. And the mother passed away. The 3 boys all survived. And the father is alive, but he lives about 100 miles away, and they haven't been able to get home yet, so they've just been living at the hospital. And in the meantime, little Ibrahim has gotten sort of attached to one of the nurses there, this woman named Isata Kalon. And he would always walk by the nursing station to visit her. He would like blow her kisses and wave. And then one day, he walked up to her and he asked her very boldly, and I like to imagine that he was wearing this blazer when he did, he said, "I want you to be my wife." And she said, "I accept." And so they sort of played this game over the next few days, and then it was finally arranged for him to make it back to his family. And I asked her, you know, how do you feel about him going home? And she said, well, I'm very happy that he's going to be reunited with his family, and I praise God that he has survived, and you know, our efforts were not in vain. But I am going to miss his presence because he is my husband now. So It is a very dark story. It's a very terrifying disease, but it is in the end a disease that affects humans, and it affects 3-year-olds that are just like any other. So I'll end it there. Thanks.
Thanks, Anders. I do think you were born here. No, maybe not. But our next person was, I do believe. Right? Oh. So we're going to try something now with a little technology. We hope this is going to work okay. We're going to try and Skype to Dr. Ben Levy, who's from this area originally. Many of you may have known him when he was growing up. He went to high school here. Eventually went to college here in Michigan, but then went to Emory University for medical school. After that, he went into emergency medicine and was working with Doctors Without Borders in Africa for some time. He's gone back now and is working with the CDC as an epidemiologic investigation service. And Ben asked me specifically to tell you that what he is going to say tonight is not, he does not represent the voice of the CDC. He's not at this point permitted to talk like that, but he is going to tell us, hopefully, if we can do this. There he is. Hey, Ben. He's going to tell us a little bit about his own experience in Sierra Leone, where he has spent some time as well. So, Ben, can you hear us all right?
Well, thank you. Thank you for allowing me to speak tonight. So growing up in Leelanau County, Traverse City was always the big city down the road, and NMC was the college where all the big kids go. It's quite exciting, therefore, to be asked to speak to you tonight with such an esteemed panel of professionals on the virtual stage with me and speaking about such an important topic. It is truly an honor to spend this evening with the big kids. So thank you very much. I did grow up in Northport, and during my senior year of high school, I wrote an essay on plagues and infections. And this essay included a hypothetical outbreak of typhoid fever at a restaurant in Northport where I had spent a number of my summers washing dishes and emptying grease traps. I still feel that this was one of my high points of intellectual passive aggressiveness. But since that time, I have always had a fascination with human illness, and the desire to chase diseases has followed me all the way through my medical education. I joined the CDC, the Centers for Disease Control and Prevention, about a year and a half ago. And for someone who always wanted to be thrown in the deep end of public health, it was very fortuitous timing. I'd only been at the CDC for about 6 months when we started hearing rumblings of the emergence of Ebola in West Africa, a place where Ebola had not been before. In July and August of this year, as the epidemic grew, it grew beyond anything that we had ever seen before, and the CDC's response grew as well. The CDC's historic role in previous Ebola outbreaks has traditionally been to provide epidemiologic technical support and to establish laboratory capacity for field testing. However, this outbreak has outstripped all traditional international systems of dealing with this disease. Therefore, the CDC's initial epidemiology and laboratory task force has now grown, divided, and multiplied. There are now hundreds of CDC senior scientists and physicians working on teams devoted to epidemiology, domestic surveillance, clinical consultations, laboratory diagnosis, health communication, infection control, border health screening, and even a well-publicized rapid response team, which can mobilize and deploy to any domestic case of Ebola within 24 hours. This is an unprecedented CDC response. Never before has the agency devoted this amount of resources to a single outbreak in such a short amount of time. I became involved in this outbreak as the CDC's response grew beyond that original task force. I was first deployed to the CDC's Emergency Operations Center, where I collected and organized the data coming in from our field teams in Guinea. I also, at that time, answered phone calls from American physicians worried about patients with recent travel to West Africa. As a physician, I was able to talk these doctors through the CDC algorithms for determining the level of risk and the need for testing. I received calls that involved high-risk patients requiring isolation and expedited laboratory testing, as well as simpler calls about disease transmission and symptoms. Usually, these calls were straightforward, and a simple decision tree was used to separate no risk from low risk from high risk, depending on the dates of travel, the location of travel, the types and the amount of contact with sick people, and current symptoms. The high-risk cases, of course, had to be referred up the chain of command, as news media and political scrutiny on these cases was intense. However, as the outbreak spread from its epicenter in Guinea to the neighboring nations, the need for field personnel grew. In August, I volunteered to deploy and was sent to Freetown, Sierra Leone. Anders and I must have revolved around in fairly small circles during that time, as several of the points he brought up in his talk rang a familiar bell to me, but I don't remember ever meeting him. The major CDC activities in Sierra Leone revolve around 5 key public health activities: epidemiology, which is counting cases and tracking contacts; infection control, which is training and securing health worker safety; communications, or educating and informing the public; laboratory testing, which is establishing hot labs in the field; and border control, health screenings at major ports of entry and exit to those countries. The team on the ground in Sierra Leone is over 50 personnel, and the team members typically rotate through on 30 to 60-day deployments. CDC personnel have now deployed to all nations in the affected region, including Guinea, Liberia, Sierra Leone, Senegal, Nigeria, Ivory Coast, Mali, and the Democratic Republic of Congo. As of last count, the CDC had over 170 employees deployed to Africa. When I deployed to Sierra Leone, I was assigned to the International Infection Control Task Force. I was put in charge of training proper infection control in the primary healthcare system. The baseline healthcare system of Sierra Leone consists of fewer than 20 hospitals and approximately 1,200 basic healthcare clinics for a population of over 6 million people. These numbers may not sound so bad, but prior to the outbreak, there were only approximately 120 doctors in the entire nation and fewer than 1,000 nurses. And most of those medical practitioners practiced in the larger cities and the academic hospitals. If you do the math, you realize that most healthcare clinics and most healthcare is not being delivered by either doctors or nurses, but by a mixture of medical technicians, midwives, and health attendants. This is one of the most rudimentary and poorly funded healthcare systems in the world. And now that Ebola has arrived, most hospitals and most medical staff, most hospitals are either closed or have been converted into specialized Ebola treatment facilities. Therefore, the primary care of 6 million Sierra Leoneans has fallen even more so upon these small peripheral clinics. And while these clinics are staffed by competent and caring health professionals, these professionals are completely overwhelmed and undertrained for the tasks they are being asked to do at this time. And these practitioners have never been given training in personal protection and infection control. Furthermore, most of these clinics, at least the clinics that we assessed while we were there, were not routinely provided with even the most basic healthcare protective equipment, such as exam gloves, gowns, or basic cleaning supplies. This is the reality in the Sierra Leone healthcare system. And this is the cadre of healthcare workers who are suffering the worst burden of deaths in the Ebola epidemic. So far, over 100 healthcare workers have died of this disease in Sierra Leone alone. And most of those workers have not been workers that have been stationed inside the specialized high containment Ebola units. The project I was assigned was a daunting project, and we certainly faced a large number of challenges while I was there. I was really only able to implement the very start of the project before I handed over to another team and rotated back to Atlanta. However, last week I was informed that one clinic we trained had received a family of 9 only 2 days after the training occurred. All members of the family were ill, and the staff there recognized the potential for Ebola, isolated the family, and alerted the proper authorities while donning protective protective personal equipment that we had donated. 8 of the 9 family members tested positive for Ebola, including a 2-month-old child. The mother was the only family member to test negative, and none of us know why she was not infected. I don't know the outcome of that family, but what I know is that the director of the health facility called our team later to tell us that the normal procedure that the clinic would have otherwise followed was to place that family into a crowded waiting room, to examine that family without any protective equipment, and very likely to have sent that family home to be cared by relatives, neighbors, and friends, as that is the way most healthcare is delivered in this country. I left my project in mid-October to return to my regular duties. I am now back at my normal desk, but I do keep in touch with the new teams on the ground. The project is starting strong, and supplies are rapidly moving out into the smaller communities in Sierra Leone. However, as of the last situation report from the WHO, the outbreak in Sierra Leone is continuing to grow at this time. And it is an enormous crisis. There is no other way to put it. But there are some signs of hope. The case counts in Guinea and Liberia seem to be slowing. Border control and surveillance mechanisms in the less affected nations, including our own, seem to be effective at keeping other cases out. The response by the international community on the ground is still increasing and may actually be catching up to the outbreak. And while it is still far too early to know how this will play out, and while at the moment the situation is still dire, I'm going to hang on to that hope because I have to. I feel privileged to have taken part in this response. I feel very fortunate to have played a very small role in one of the defining public health events of the new century. However, my colleagues and friends in Sierra Leone are constantly on my mind, as are the brave healthcare workers who volunteer to step into the treatment centers and primary care clinics every day. For all of them, I hope this catastrophe ends soon. Thank you for having me here tonight to speak about my experiences.
Thanks very much, Ben. Well, that was very interesting. So we're going to move on from looking at the global perspective, and particularly Africa and what's going on there, to bring it back down more locally here. And of course, you're all aware of what's been happening in this country, and not a lot that's been happening in reality, but certainly been a lot in terms of the news media and the politicians who want to jump on the bandwagon. But we would like to call on Wendy Trute here now, who's the health officer to Grand Traverse County Health Department. She's been here since 2012, and she has an excellent background in public health. She's been doing this for 19 years. She was the senior epidemiologist for the Minnesota Department of Health, the cancer registry director for the Washington State Department of Health, and epidemiologist for the Idaho Cancer Registry. She has her master's in public health from the University of Michigan, and we're going to ask her to tell us about what's been going on in the public health department here. So, Wendy, thanks.
Well, like Anders, I have a confession. I wasn't born in Traverse City. Not quite as bad as Ohio, but I am a Youper. So I was born and raised in northern Michigan, but have considered Traverse City my home for the past 20 years, as all my immediate family live here. So I was kind of waiting for the opportunity to get back to Traverse City, and am privileged to be able to come back and serve as your health officer. So at the local level, local health departments really serve as a liaison in the community for preparedness. We are coordinating with public health agencies at the state level, looking for guidance and protocols that they have, as well as Centers for Disease Control. And the Centers for Disease Control is really taking the lead on all the protocols and the guidance, and it's really almost a full-time job to keep up with the changing guidance as emerging infectious diseases kind of progress and we learn lessons. The guidance, it gets tweaked and changed, and so that's one of our main roles, is making sure that our community partners are aware of kind of those changes and anything that's new. We also coordinate with local health departments in our region. We're an integral part of the hospital preparedness at Munson, and Dr. Speirs is going to give a great presentation on their whole plan, so I'm not going to go into detail on that. But we also help coordinate with first responders in our community. making sure that the 911 center is doing the proper screening. So if somebody calls and I think there's a list of 12 different symptoms. If they give one of those, the next question is, have you traveled to one of these West African countries? So that they could immediately alert EMS or a hospital that there was someone who was considered to be, I guess, suspicious. We're also working with law enforcement, fire, and EMS to make sure that they have the proper personal protection equipment. You'll probably hear the words PPE a lot, personal protective equipment, and the putting on and taking off, also called donning and doffing, in the technical terms, are really key and really important to protecting healthcare workers. So one thing we're doing is making sure that they have the adequate supply, making sure that they're practicing taking it on and putting it off. And it doesn't sound like it'd be that difficult, but having watched Munson recently go through an exercise doing it, it's a very, very difficult task. So the health department's also really busy preparing ourselves for what our direct role is. And one of the major things is preparing for the monitoring of movement. And that means being prepared to accept a traveler in our jurisdiction who comes from one of the West African countries and perform active monitoring, being prepared to issue a voluntary agreements for quarantine, being prepared to issue a quarantine order if someone becomes non-compliant and it's a high risk, and working with law enforcement and our local prosecutor to prepare them for their potential role of serving and issuing the quarantine. And also finally, something that we do every day with infectious disease is preparing to do contact tracing if we were to get an Ebola case. So the monitoring of movement is one of the many layers of protection in public health throughout the United States, and it starts with entry screening at the U.S. airports. Currently, anybody who's coming from West Africa from one of the 3 countries, Guinea, Liberia, Sierra Leone, and if they have to fly into one of the 5 airports listed: John F. Kennedy, Newark, Chicago O'Hare, Washington Dulles, or Hartsfield Jackson in Atlanta. Visitors must provide primary and secondary information, including email, telephone, address. They have a backup contact, so there's lots of information that we have so we know how to continue to monitor them as they move throughout the U.S. They're also given care kits, and the care kits are shown here. And those include a tracking log, a description of Ebola symptoms, a thermometer that's just for them personally, instructions how to use the thermometer, and a wallet card, who to contact if they get symptoms. They are screened at the airport, and if they're screened for risk of Ebola exposure, their temperatures are taken and they're screened for Ebola symptoms. If they have yes answer to one of those, then they're further referred to CDC, who then can assess whether or not they can continue to travel or not. If they're sick, they're taken to a hospital, evaluated, tested, and treated. Or if they determine that they are able to continue to travel, then they're referred on to the next leg of their journey. So if they're allowed to travel and they come into the Grand Traverse region, what would happen is that we would actively monitor them for 21 days. A local health department nurse would work with them, and they would interview them initially, kind of assess their level of compliance. They would have to report their temperature to us 2 times a day and any symptoms. If they're allowed to travel once they arrive at their final destination, if they're considered to be no or low risk, actually in the low risk category, then they would still have to work with us to let us know anytime they're traveling out of our jurisdiction so that we can make sure that they're continuing to be monitored. If they fail to maintain the daily contact, then we would be taking immediate steps to locate them and reestablish that daily contact. For those who become ill or symptomatic, we would notify Munson immediately so that they're able to prepare to isolate a patient upon arrival. We would make arrangements to safely transport them. In our community, we have 2 EMS units who have specially, there's 2 kind of strike teams that are trained and practiced so that they could handle someone with symptoms. And they have it set up so it could be easily decontaminated and would kind of expose the least amount of equipment and the least amount of people. Or if the person was well enough, we would have them drive their own vehicle, and then we would work to decontaminate that vehicle. And then Munson's Ebola plan would be initiated. Going in the wrong direction. This slide shows the 4 different levels of epidemiologic risk based upon the different kinds of exposure. So there's high risk, some risk, low but no risk, and then no risk. I don't expect you to read it all, but I'll give you some examples. So a high risk exposure would be someone who's had direct contact with bodily fluids from a person who's sick and showing symptoms, either through a needle stick or they've touched a fluid. Low risk would be someone who was in a country with a large Ebola outbreak within the past 21 days, so that's the incubation period, but did not have any known exposure. And no risk would be someone who's had contact with a sick person with Ebola before they had any symptoms. So that kind of gives you a little idea of the scale of risk. And this slide shows the risk categories and the public health response that results. And keep in mind that this is for people who are not symptomatic, so no symptoms. So in the high risk category, they would be direct, actively monitored, they would have travel restrictions, and they would have restricted public activities, while someone in the low risk category would have active monitoring as well, but would not have travel restrictions and would be allowed to go out in public. These are all public health actions that are recommended to help protect the public by preventing the spread of the disease from people who may have a contagious disease. So currently in Michigan, and this is updated every Monday on the state health department website, there are 5 people who are currently being actively monitored. They are all low risk, and 9 have completed the monitoring cycle. So we've had 14 total in our state who have traveled in through these checkpoints that we've monitored at a local health department level. There are none in our community. There's some additional public health actions that are recommended to help protect the public. Isolation, and that's when you separate ill people who are infectious from people who are not sick. In the case of Ebola in the United States, that would be done at the hospital. There's quarantine, and this really separates and restricts the movement of persons who are exposed but not ill from other people, and that's, again, to protect others in case they become infectious. And that can be done with or without the requirement that they're contagious at the time, and it can be voluntary or involuntary. Active monitoring means that public health workers would be responsible for checking on these people at least 2 times a day to see if they have any elevated temperatures or any of the symptoms associated with Ebola. And all people who fall into the high or the some risk category would have direct active monitoring. And that would mean that a public health worker would go to their house at least once a day and follow up with at least a phone call, possibly a second home visit for a second time that day. Travel restrictions are just that they cannot travel long distances by airplane, ship, bus, or other kinds of public transportation, even if they're not sick. And that, again, is to prevent the spread. And then restricted public activities means that they can't go into public places like a mall, a school, church, movie theaters, things like that. But they might be permitted to go jogging in a park as long as they're keeping at least a 3-foot distance from someone else. So to some degree, some of this is, it's based on risk, and it's also based on some level of judgment and kind of determination. And local health departments have the authority in the state of Michigan to issue the isolation and quarantine orders. This graph shows contact tracing. Contact tracing is something that's really important in any infectious disease, particularly with Ebola. It's something that's an effective tool that we utilize in public health every day. For the past week, we've been utilizing a lot on pertussis or whooping cough in our community. So it's vital that it stops the spread of deadly infectious diseases. And when a patient's diagnosed, a public health nurse interviews them and then determines who all the people were that were in contact with that person. And then we would interview all the people who were in contact to find out if they are symptomatic, determine their level of risk, and to make sure that they're not infected. And if one of those people becomes symptomatic, they would be further evaluated, and then we would monitor them for signs and symptoms of Ebola for the next 21 days. And this continues with every single contact. So it's kind of this continuing circle, and as you have a new case come up, then you start that process over again. It helps diagnose patients quicker and earlier in the process of their illness. It improves the likelihood that they will be cured and reduces the chance that they'll infect others. It's really important regarding Ebola because if we can find the patients early in the course of illness, before they're starting to vomit or have diarrhea, then we can significantly reduce the exposure to others and healthcare workers. Another important part of this is risk communication, making sure that those who are considered contacts understand their level of risk, understand what's expected of them, what they can do, and also putting the risk in perspective for the public. So just some final thoughts. I've kind of described all the different layers of, I guess, public health planning and screening activities that are put there to really enhance your level of protection. And just to say that on a day-to-day basis, Ebola risk in our community in Grand Traverse County is really not significant, and that there are other things in our community that we should probably be more concerned about right now: influenza, pertussis, and enterovirus D68. Thank you.
Thank you, Wendy. So we're going to move on to our last speaker then, and then we'll have questions and answers after that. Introducing to you Dr. Karen Speirs, and Karen is one of my associates at Munson Medical Center in the infectious disease section. She joined us there in, when was that, Karen? 2005, I think, wasn't it? Yes. So it's been that long, gosh. Time flies when we're having fun, huh? She's an outstanding clinician, diagnostician. She did her infectious disease fellowship at William Beaumont Hospital. She is presently the medical director of infection prevention at Munson, and she's also the president of the medical staff, as if she didn't have enough to do. She's a fellow of the Infectious Disease Society of America, and she spent a lot of long hours recently developing plans for the hospital and the hospital personnel as how we deal with this if we do get a patient who is infected at Munson. So Karen, turn it over to you.
Thank you very much. It's tough being last, let me tell you. And I have one question for Ben. Did he wash his hands with that Salmonella typhi outbreak? That's all I want to know. All right, we're going to talk to you about Ebola preparedness at MMC. This is the Ebola virus. It has 7 genes. It's a filovirus, and since I'm an ID doc, you're going to have to listen a little bit about the background here. It's not a bad-looking virus if it's not in your body. Basically, what we did was we looked at Terrie. Everybody already gave you the statistics and how many cases there were. You know, there was about over 13,000 cases in Africa as of November 7th, and about 4,000 of deaths. Basically, why is there the spread there? The spread is there simply because you have a dense populated area. There's not any borders between the 3 countries. There are borders, but you don't see the borders, and they go back and forth between the countries quite readily. It is the first outbreak in a major metropolitan area. They do not have the public health infrastructure, as you heard already in Africa, that we have. They don't have the facilities. There was an article I read about Germany building some hospitals. They're a 100-bed hospital in this one area, and they're getting 300 new cases of Ebola a day. So we're trying, but we're behind. We just cannot catch up with Africa. And so one of the things that you do, you look at this. You see this Ebola facts of facilities in West Africa, the patient being taken care of there. They've got buckets where they have their waste, their vomit or their diarrhea. There's an isolation unit there on your right. As you can see, it's a fence. So their isolation is much different than ours. And I'd like to show you, compare it to ours. Right there in the United States. So this is one of the reasons that I think our mortality is going to be much lower. We have the facilities to isolate. We have the facilities to protect the healthcare workers. We have the ability to rehydrate these people. We have the ability to replace their electrolytes, and we have some treatment that Africa has not even offered. As you can see with the doctor that came back in the end of July and the nurse that came back, and they survived. We really started taking notice. About that time, we decided at Munson Medical Center that we needed a policy. So we developed a policy on August 1st. And it was very comprehensive at that time. It was all the way from transmission to what we do when they walk in the door, what we do to isolate, what we do to even dispose of the body, because that is some consideration that you have to think about. In Africa, this is a big problem because there's people who have died and there's not even anybody to come pick up their bodies, and that spreads the virus even more. The spread of the virus, but the spread basically is through body fluids. It's not through the air. You cannot, let me see if I can get the next slide. Oh, this is a good one. You cannot get it through the air. You cannot get it through water, and you don't get it through food. You get it through blood or body fluids like urine, saliva, sweat, feces, vomit, breast milk, semen, objects that are contaminated with blood. You can get the virus. Infected animals, bush meat, which is wild animals in West Africa that they kill, and the handlers of that can spread it, and contact with the fruit bats, because that's the reservoir, we feel, of the Ebola virus. Continuing on, I want to emphasize that a single drop of blood contains millions of viruses, and it can remain alive in blood for many days. And if it's on doorknobs, anything like that, it can last for several hours. So when we look at the Ebola outbreak, I think the important thing on this slide is not only the symptoms, but you can only spread it through once the symptoms begin. And I think that's an important concept that you need to know. So like the flu, you can spread 24 hours before symptoms begin, and that's why it is so contagious. But with Ebola, it is when symptoms do begin. And then the incubation period is 2 to 21 days. I know you've been hearing a lot about this 21 days. At 21 days, we feel that you're pretty, well, if you have not come down with symptoms, you are not going to come down with the symptoms of Ebola. So when you look at this, fever, headache, diarrhea, vomiting, stomach pain, muscle pain, what does that sound like? Sounds like the flu, doesn't it? So it's very important that in unexplained bleeding or bruising, that only happens in 5 to 7% of people in Africa or anywhere else, and it's usually GI bleeding. That's the most common bleeding. When we go farther, clinical features, it gets inside your bloodstream, it goes to your liver, spleen, lymph nodes, and then you get the vomiting and diarrhea, you get dehydrated, you get electrolyte imbalances and nutritional deficiency with the Ebola. So then the Michigan Hospital Association decided that they put out a letter to us, and this was in August, and they said, anxiety may be greater than the threat of harm, but every hospital must be prepared by how are you going to handle a patient? How are you going to screen them? How are you going to isolate them? How are you going to protect your staff and other patients? And how are you going to protect the community while still treating this patient? And so we really then started looking deeper into what we were going to do. And I can tell you it's a wake-up call when someone comes over, for instance, the doctor that came and the nurse that came with Ebola. Well, it was on September 30th that basically we diagnosed our first case here in the United States, when it was the gentleman from Liberia that came to Dallas, Texas, in the Presbyterian Hospital, Dallas Presbyterian Hospital, and we diagnosed our first case at that time. So Munson Medical Center decided we really need to be prepared. We've got a plan, we have to have policies, we have to have procedures, education, and drilling. And that's the important thing. And this is kind of our motto: detect, protect, and respond at Munson Medical Center. So how did we do that? Well, this is the first policy on August 1st that was written. And as you can see, transmission, it included transmission, signs and symptoms, exposure risk, lab testing, specimen handling, treatment, prevention, all the way down arrival, pre and post arrival, infection control, what do we do when someone comes here, how do we clean the room, how do we clean everybody, transfers and handling of remains. So what we did was we decided that we needed to develop a core team, because we were finding that everybody was meeting and covering the same territory. So we decided at Munson to do an Ebola response team. So we do have our Ebola, and you can see it's multidisciplinary. It includes biohazard preparedness. It includes chief medical officer, community relations, emergency department, EMS, first responders, environmental services, facilities, infection prevention, infectious disease, laboratory, medical ethics, nursing administration, nursing supervisors, pharmacy, safety, supplies, Grand Traverse County Health Department. Wendy's been to our meetings every day, affiliate hospital teams. And we formed this committee, and we met daily. And I can tell you the first time we met was over an hour, hour and a half, and it was the details that got us. Every single day there was more and more details that we had to get. We had to buy our protective equipment. We had to learn how to put it on and put it off. We had to buy more protective equipment because we didn't seem that worked. And so we really spent a lot of time in this, and we're still meeting. So we decided with the Ebola response team that we were going to stop, protect ourselves, and protect others, and so we developed our plan. It also included screening, and this is how we screen people in our community. We have a hotline, we have a line that you can call into Munson Medical Center and answer questions about the Ebola. If you think you've been exposed, if you've come back from Africa, if you're in contact with somebody who has come back in Africa, we have a line that you can call into the hospital and ask questions. There's in-person screening when you come into the hospital, and I'm going to show you the signs when you're coming into ER that will screen. And those are self-screening. When you walk into our hospital, there's signs there, and we say, if you have any of these symptoms, and if you have had any contact, please put on a mask. Please walk out of the hospital and around to the emergency department if you need to come into this hospital. And this is a picture of the slides. This is our screening protocol. These are our signs that we have out in front of each of our doors and entrances at Munson Medical Center. And it asks you those questions. And this is our kiosk with the mask, as you can see off to the right-hand side. After that, then, if you go to the ER, you come into the ER, every single person is screened. Before you get past the second door of the ER, you're screened, and you're asked, what are your symptoms? Do you have fevers? Do you have vomiting, diarrhea, muscle aches? What are your symptoms? And the very important and, is have you been around anybody with Ebola? Have you been to these 3 countries? And if you have, then immediately it starts our protocol and our checklist. And they call the response team. We are all called in. We all have beepers that are in that response team. We come, and then we can call other people in our departments if needed. Here's our checklist put out by CDC. We fashioned it after the CDC. And how we started our protocols. We have a much larger one than this, but this was our first one that we started with. And this is our response planning, just to show you the details of this. These are 2 rooms in the ER. The minute we have a patient put in room 16, which is the red on the lower right hand of this diagram, then we have a wall that comes down, a plastic wall that's all sealed, closed, that seals off this whole section of the ER. We have a clean room, we have a dirty room, we have a bathroom, we have where you can walk, where you can go to don and doff these, the protective equipment. So we have everything worked out there. What do we do about labs? You can't take blood and send it to the lab because you would contaminate everybody in the lab. So we have point-of-care testing. We bring a machine in that will stay in that room. We test them for the electrolytes and anything else, including malaria, because malaria is probably one of the main things that you're going to see coming back from Africa with fevers. So this is what we look like. Truly, this is what we look like. It takes about 40 minutes to put this on and to take it off, but not a piece of skin is showing on these. It's pretty hot. We have pampers, we have double gloves, and we have even antimicrobial tape on there. The person on the left is the helper. There's always a helper. You'll never be alone taking it on and off, so you make sure you do not contaminate yourself. So they take it on and off, and we practice this. You have to practice and practice and practice, and it takes 40 minutes to do this. And then we find out, well, maybe we should get a different type of hood. Maybe we should do this. So by now, we're getting pretty good at this. So you can see this is what we look like. So I told you about the lab testing. Treatment protocols, what are we going to do if you come in? Number 1, we're going to hydrate you. Oral hydration. We're going to put IVs in you. We're going to replace your electrolytes. We're going to give you oxygen if you need it. We're going to take the malaria slides and treat you for malaria. We're probably going to do antimicrobials if you have diarrhea, because there's other reasons that you have diarrhea coming back from Africa. You have the whole blood immune system, or serum. This is what was given to the doctor and the nurse at Emory University. And it works. Monoclonal antibodies, of course, are being looked at, and so are some of the other antivirals. So what do you do with cleaning? Infection control is very important with this when you have a patient in there with possible testing. And with the testing, you can test. We send it to Michigan Department of Community Health. They have a PCR test now. We can get it back within 24 hours. However, we have to wait and retest after 3 days because the viral load may have not been high enough right at the beginning of the disease. So we have to retest it at 3 days. Infection control, alcohol-based hand sanitizers work, bleach. Bleach always works for everything, 10% bleach. And look at our little robot down there. Can you see the picture there? We have a little UVC light that kills just about everything. You put it in, and within 20 minutes, the UVC light will kill all viruses. And we just got that. We're so proud of our little robot. So medical waste management, Category A, infectious substances and regulated by the U.S. Department of Transportation's hazardous waste and regulations. And so we have to be very, very careful about the waste. We have to try to inactivate it either by autoclave or by incineration, and incineration is what is recommended. Okay, physician outreach. We've really done a lot of physician outreach in our core group because we want our physicians within the community, we want our urgent care facilities, we want the other hospitals in the area like Cadillac and Grayling and all the surrounding hospitals to know what's going on and know what to do and to be to be able to be prepared. So we're sharing everything. They're in on a teleconference with our meetings every day. They have access to all of our policies and all of our suggestions. We also had an in-service. You can see me with Al Pylong, who's the CEO of Munson Medical Center, where we did a live, we did a little information to all our employees that came through. That was on the intranet, I'm sorry. Yeah. And so what about prevention? Vaccine trials. Now we're going to go global again. We're going to get out of Traverse City and go global a little bit. Vaccine trials are underway. They are now saying in December they're going to start using vaccines in West Africa, and they predict by mid-June that there's going to be hundreds of thousands of doses of the vaccine in Africa. So let's keep our fingers crossed. And active monitoring, Wendy already had talked about. So I'm going to finish up with a perspective. And I want you to think about this. When we talk about influenza, in our country alone, there's 3,500 to 49,000 deaths a year from influenza. I want you to think about that. Back in 1918 with the Spanish flu, depending on who you talk to and what you read, it can be 60 million to 100 million people died from the Spanish flu in 1918. You know, I want you to put this in perspective of what we're seeing today. It was airborne, and you can spread it without symptoms, so that's why you can see it going around much quicker. Same with measles. 2.2 million people died in the world every year before the vaccine, and now it's come down to about 122,000 per year in the world that die of measles. And they infect about 12 to 18 people per person. And then Ebola, it will only spread when symptoms occur. It's not airborne. And average is 1 to 2 people spread with the Ebola. So I love this little algorithm here, or logarithm here. See the X on the left? That's your chances of getting Ebola in the United States in the next year. When you go farther, your chances of, the little airplane is your chances of dying in an airplane crash. Let me see, what is it? The lightning's after that, dying with lightning strike. The next one is bee sting, thank you, it's a bee. Being eaten by a shark is the next one. Being killed in a car accident is way up there on the right. And then the X is simply contracting Ebola in Monrovia. So when you look at that, you know, you have a 1 in 13.3 million chance of contracting Ebola in the United States in the next year. 1 in 11 million of dying in a plane. 1 in 9.5 million dying of lightning strike, 1 in 5.2 million dying of bee sting, shark attack, 1 in 3.7 million, car accident, 1 in 9,100, and 1 in 5,000 if you're in Monrovia. So my very last slide is, I want to emphasize that the risk in Traverse City is very, very low for an Ebola outbreak. However, we do have an international school here. We have a large travel population here, so we cannot say that it's never going to happen. So we are prepared, and I think Munson Medical Center and the community is prepared, and that's the message that I want to get across to you. Jan Swift, who is our infection prevention manager, has been in contact with Emory University when we were developing our protocols, and they said we are far and away more advanced in our program and protocols with the Ebola than most of the country. So I'm very proud with all the hard work that our core team has put into this. So I think that you can rest easy. We have a plan, and our risk is very low. Thank you.
Thanks, Karen. That was great. And thank you all for sticking around this long. So now it's your turn. We want to open it up for questions and answers, or at least questions. We don't know if we'll have all the answers, but our panel's going to stick around and try and answer any. We have microphones if you'd like to, but if you'd rather just raise your hand, just go ahead.
What is Munson's estimated capacity for high-risk patients?
Can you all hear well enough to repeat that? Okay. What is Munson's capacity for handling cases, high-risk patients? Karen?
That's a good question. Not that many. We figured 1 or 2 patients is all we're going to be able to handle at Munson Medical Center and do it correctly. But MDCH, which is the Michigan Department of Community Health, is creating a list of we don't want to call them Ebola hospitals, but hospitals downstate that will be the center if there is an epidemic or a large number of people that come in contact with that. Here at Munson, we are considering 1 to 2 patients, and that's it.
Okay, another question back here.
Rob Lovell, Traverse City. Question regarding the epidemiologic things that we've learned. If this being the 25th outbreak, is the frequency or decrease, or the rate of time between the frequencies of outbreaks decreasing? One was 24, one was 23, so on back.
Terrie, would you be comfortable trying to tackle that one?
You gotta turn it on.
That exactly, but my sense from reading the literature is that each of the epidemics is like Dr. Martin's grandma said. They're all unique and individual, and each has its own constellation of risk factors and transmission dynamics. So I don't think that you can compare them each to each other very well. We were talking earlier today about the virus itself. And is the virus from the first epidemic the same as the virus we're seeing now? It is in name, but I haven't seen any data on the molecular comparisons of these viruses. So I don't know how much the virus itself has morphed over the course of all these epidemics.
Okay, right down. Right down here.
And also keep in mind that Dr. Levy is back with us as well and can take questions.
Well, they say that it's an ill wind that blows no good, and this is obviously an ill wind. But it occurs to me that this might turn out to be a dry run in a sense that may benefit the world in the future, because we've heard in the past that the potential for, huge outbreaks of infections that could go from continent to continent in the next century is quite great. And here we have one that, as bad as it is it looks like it is probably going to be limited to that area. And here we have the whole world, right here in Traverse City. We have people who are gaining expertise in dealing with it. And we may say someday, thank God that we went through this, when something comes along that really does spread throughout the world.
Thank you. That's an excellent comment, and I think we would all agree. And that's one of the reasons that I know the CDC and World Health Organization and groups like that are really trying to promote the increased ability to detect these new infectious diseases, because they are occurring much more frequently than they used to, mainly because we're a global village now. We were separate countries, thousands of miles apart, but now we're all living in one small place and traveling to each other's places all the time. So you're absolutely right. Down here.
Hi, I'm Valerie. Hi, Terry. Can you give us a little more information on the vaccines? And I know you mentioned it, Dr. Speirs, but just a little more information. I have a daughter who will be going to Ghana in 2016, so I kind of want to educate myself a little bit.
Karen?
Well, as I said, they're advanced to the point where they are going to start using them in West Africa in December. Originally, it was in January. Now they've moved it up to December. So I think that within the near future, you're going to see that we're going to have that available also to our travelers.
Just another comment on that. I just saw a report where they've done the testing in monkeys already, and it's 100% effective. And it is an intranasal vaccine, and it's not affected by temperatures, so you can transport it easily in third world countries. So it's looking very hopeful. Down here.
Yeah, John Shield. I understand there are several other hemorrhagic viral diseases in Africa that haven't really exploded like this one has, but the potential is there. Could you comment on that?
Terry, you want to try and take that? Or Ben, you want to try? Can you hear the questions there, Ben?
I may have to get some of these questions repeated if they come my direction.
Okay. The question was that there are a number of other hemorrhagic fevers in Africa. None of them seem to have exploded quite to this extent before. Any comment on that?
Well, sure. I mean, I'm not by training an infectious disease specialist, and so perhaps others would be more qualified to answer. But there are 5 different subtypes of Ebola itself. Those are all hemorrhagic fevers, and I believe you guys showed the map of all 25 outbreaks in history. That's a range of different Ebola outbreaks. So we've already sort of documented different types of hemorrhagic fevers having occurred. There's also Marburg and Lassa fevers, and actually Lassa fever, one of the world headquarters or the hotspots of Lassa fever was in Kenema district of Sierra Leone, where Anders was showing you pictures earlier. So this part of the world has seen hemorrhagic fevers before. There is knowledge of some hemorrhagic fevers. Frankly, Ebola and Ebola Zaire, which is the strain that we're seeing, is the more virulent and lethal of varieties out there. So the others are, at least historically, more easily contained than this outbreak has been.
Okay. A question back here.
Yeah, Tom Kelly, Suttons Bay. We've learned that we're at a pretty low risk here locally for Ebola, but what can we do to convince people in our own community to get vaccinated, have their kids vaccinated for diseases that we already know how to control?
Gee, do you think?
Well,
Preaching
yeah,
to the choir.
particularly, and Dr. Speirs and I have talked a lot about this, the flu vaccine. We want to keep as many people out with normal influenza out of the ERs and the doctor's offices as possible, especially given the crossover of symptoms. But vaccines in general, yes, vaccines are near and dear to my heart. I wholeheartedly agree with them, and we are dealing with a large whooping cough outbreak right now, partly because of people not getting vaccinated or not following through on the prophylaxis and treatment. So to convince them, I'm seeing a lot of good dialogue actually in the social media, and a lot of people kind of saying, you need to get vaccinated. So I think it's going to take a whole community response. Vaccines are as much about the whole community and the protection as they are the individual, and we need to get back to that.
This is a question for probably Dr. Speirs and Mr. Kelto, but I noticed when you were in your travels and you mentioned you were stopped up to 8 to 10 times for a temperature check. I'd seen this on television reports. It didn't appear to me there was any infection control prevention in the use of those people taking their temperatures. So in other words, it looked like they were touching a cheek to one person and going right next to somebody else. And I'm curious about that. Perhaps, doctors, maybe, do you have a comment about that?
Yeah, they don't actually touch you. It may have looked like that in the photo, but these thermometers are designed to be held a certain distance from your head, and I don't know exactly how they work, but they're able to take your temperature without touching you, and I think that's why that particular version has been so popular.
Okay, down here.
Anders, one of your objectives is to get close to the story. What precautions do you take to protect yourself? What does NPR tell you to do and to not do when you're a journalist in the field where Ebola is the story?
Sure. Well, first of all, they told me I didn't have to go. I was offered. They asked me if I wanted to. They said there's no penalty or anything like that if you don't go, but would you be interested in going? Would you be willing? So I did some research. I was, of course, a little nervous about it, but the more I read, the more I understood how it's actually transmitted, the safer I felt about going, assuming I took certain precautions. We had a number of security briefings at NPR as well before I went to make sure that I understood what I needed to do to keep myself safe. The most important thing is to not go into an Ebola treatment unit and to not have any physical contact with anyone who has any possibility of being infected. So that was the main thing that we did to stay safe. We never went into the units. As you saw in that photo, we stood outside and spoke across that fence. We avoided shaking hands with people, even though that's a very unlikely way of transmitting it. And we were just extra cautious. We used a lot of hand sanitizer. We brought Clorox wipes. We would always wipe down our bags or our hands or the surfaces of things that we were going to touch before we touched them, just out of an abundance of caution. And my producer and I just sort of used the buddy system. If I ever saw him do something that I thought might in some way compromise his safety, then I would point it out to him and he would do the same to me.
Okay. There's a question right down here. Oh, I'm sorry, right back there. Go ahead.
I guess this question is for Dr. Levy. Where is rare and like Fort Detrick? Where are the experts from the Army on that? Rare, Walter Reed Army Institute of Research, and the biological chemical warfare specialists from Fort Detrick, Maryland. I worked at both of those while I was a medic in the Army. Those guys have stuff that'll scare you. We're paying for it. Where is it? Every combat medic was trained to be a specialist in chemical and biological warfare. And I'll tell you, if it took you 40 minutes to get your mask and gear on, some sergeant probably had his boot somewhere you didn't want it to be, just so you know. Any ideas? Are you guys at CDC getting any help from the Army?
Liberia. That's the simple answer is that a large part of the U.S. International support mechanism has gone to Liberia. So I did not myself have any firsthand experience working with our military servicemen and women, but they are there. A big component of these 17 treatment units that are being established and set up are happening by the military, and I do know that USAMRIID, the Infectious Disease Research Institute of the U.S. military forces, is there. Sierra Leone, the British government, it being a former colony of Great Britain, has pledged its support to help the effort there, and similarly in Guinea, the French government has promised their support, and those militaries are active and on the ground. And I didn't have reason to interact directly with the British military while I was there, but I certainly was running in the same circles as them.
Okay, another question. I think there's one right back here.
Hi, Terrie. This is for Terrie. Hi, Terrie. I heard a statistic the other day, I wanted to check it with you, that while there are just under 5,000 deaths from Ebola at this time, that every day in Africa, 1,500 people die of malaria. So in 3 days, 4,500. Is that correct?
Yep, no, that's close. It's come down. So when we first started working in Malawi, there were 1.2 million malaria deaths a year, which was a child every 30 seconds. And that's cut in half now. It's still 600,000 a year, and it's a child every minute. But we're making progress.
Vaccine on the horizon for malaria?
There are some vaccine candidates. I tell the medical students I wouldn't change my investment strategy just yet on them, though.
Okay. Another question out in the audience here? Okay, right here.
I just wonder about the vaccine. If it's reasonable to think that all Africans will be accepting of it because they have been so skeptical of our help in the past?
That's a great question. Anders, could you tackle that first maybe, and then maybe Terrie could too?
Yeah, I think it will be a challenge. It varies by country, obviously. Within the 3 countries that have been most affected in this outbreak, there's been the most fear and skepticism in Guinea. That's the country where a group of 8 health workers, and including a couple of journalists, were killed as they were going around to try and inform people about Ebola. As I mentioned earlier, there was a stage of skepticism or disbelief in Sierra Leone, but they're way beyond that now. I think that's also true in Liberia, in large part due to the efforts of groups like the CDC who have worked with local health officials to really get this message out there. That said, especially in the countries that have not been affected in this current outbreak, there will probably be similar kinds of challenges, especially in the more rural areas. It's often more of a rural-urban divide in Africa. In the urban areas, you have more sophistication, more education. You get out into the villages, the rural parts of the country, you often are dealing with people with a different set of beliefs or a different worldview. So that would be my guess, is they'll run into those challenges in those more rural areas.
Okay.
Are there any more questions? Oh,
one right
all
back there.
So it sounds like we're doing the screening that needs to be done in our ER department in case of an outbreak or someone coming in, but I've got to wonder, what is the likelihood that we could even see someone that isn't already being followed because they've been seen in one of the airports in their screenings? What is the likelihood that we would even see somebody and have that be their first question that they have to answer yes to, and they're not being followed by somebody else?
Wendy?
The likelihood of that should be almost zero now, if not zero. The screening for the airports was fully implemented in October 22nd, and so some of the other screening was already in place prior to that, and I think it's just another level of protection, somewhat because of, I think, the public fear, All
right, are there any other questions? Last chance from Dr. Levy. Anders, Terrie, Wendy, Karen Speirs, or Dr. Martin. All right, well, thank you so much, our panelists. And thank you all for coming out tonight, our first snowy evening where we have to think about roads, so be safe going home, and look forward to seeing you again. Thank you. Good night.